The defect should be utilized as much as is feasible in order to enhance the function of the prosthesis. Soft silicone materials may be useful in selected edentulous patients with partial maxillectomy defects. Implants are especially useful for this group of patients since the premaxillary segment on the defect side is likely to be available for implant placement and access to the defect may be limited. Implant retained prosthesis for maxillary defects. Implants provide retention, enhance support, and improve the stability of the obturator prosthesis. Mastication is significantly improved, and speech and swallowing are made more efficient. Now, Romanas E. et al. In use of osseointegrated implants for the maxillary resection patients in proceedings of the first International Congress of Maxillofacial Prosthesis presented a data of the implant site and the relation of the implant site and the success of the prosthesis. Now, when we talk about anterior maxilla, they placed 26 implants in more than 5 patients, and number of implants uncovered are 21, buried 1, failed 3. So the success rate in anterior maxilla is 80.9%. In maxillofacial or maxillary defect patients. Now, when we talk about posterior maxilla, in 8 patients, 20 implants are placed, out of which 16 is uncovered, buried 4, and failed 4. So success rate is 62.5%. When we talk about tuberosities, the success rate slightly increases to 65%. Pterygoid plates, the success rate is 0 in maxillary defect patients. Zygoma success rate is 50%. In palate, the success rate is almost 0%. So the maximum success rate, the maximum success rate is obtained in anterior maxilla, followed by tuberosities, followed by posterior maxilla, and then followed by palate. But the overall success of this study is 67.7%, which is more than 50%. So implant is a very good option in such patients to enhance the stability or retention of the prosthesis. The most important thing is the timing of the placement of the implants. When you place the implant at the site at the time of surgery, there are chances of osteoidal necrosis because of the radiation therapy followed by the surgery. If radiation therapy is not planned, then we can place the implants at the time of the surgery. Otherwise, the implants can be placed when we are planning a definitive prosthesis after the proper healing phase has progressed. Now, this is the data regarding the radiation therapy. So, number of implants in irradiated patients, the success rate is 60.6%, but in non-radiated patient, the success rate is 75.9%. So, there is an increase of success rate of implants in non-irradiated patients, as we have discussed earlier. Same study shows this data also. And this is the picture of the implants. The implants are placed in the first picture in the premaxillary region, which is the most successful region according to this study. And this is the bar placed on the implants. Now, in this picture, this is the zygomatic implant, which is coming from the lateral aspect. This is zygomatic implant, and this is the female component, which is placed in the prosthesis, which fits in the male component of the implant, like this. In many patients, insufficient interocclusal space may preclude the use of conventional abutment cylinders. In these patients, healing abutments can be attached and retentive bars fabricated. Fabrication of the definitive obturator prosthesis can commence When the peri-implant tissue are well healed, it is usually desirable to fabricate a trial denture before designing the retention apparatus. Tapered impression copings, which engage either abutment cylinders or implant fixtures, are selected. Now, definitive obturators for dentulous patients. Dentulous patients with total maxillotomy defects. Location of the defect. Invariably, the surgical resection includes the distal portion of the maxilla and rarely does a distal abutment tooth remain following surgery. The extent of the surgical resection anteriorly does vary considerably. Therefore, a Kennedy Class II partial denture with an extensive lever arm is required for most patients. Movement of the prosthesis. The defect must be employed to minimize the movement of the prosthesis, thereby reducing the stress on the abutment teeth. In most defects, if forceful mastication occurs on the defect side, the prosthesis can be displaced significantly into the defect, and that has the potential to expose abutment teeth to damaging lateral torquing forces. Arch form. As previously mentioned, square or ovoid arch forms possess more palatal bearing surface perpendicular to occlusal stress. This provides for a more stable prosthesis during function. Partial denture design. Major connectors should be rigid. Occlusal rests should direct occlusal forces along the long axis of the teeth. Guide planes should be designed to facilitate stability and bracing. Retention should be within the physiologic limits of the periodontal ligament. Maximum support and stability should be gained from the residual soft tissue denture bearing surfaces, including the defect. The diagnostic cast should be surveyed carefully for location of undercuts, location and contour of potential guide planes, and selection of the path of insertion. If the lateral and posterior undercuts in the defect are to be engaged properly, the prosthesis must be inserted first up into the defect and then rotated up into position onto the tooth. Abutments adjacent to the defect. A tooth closely adjacent to the anterior margin of the defect should have a rest and retainer if adequate retention is to be achieved. But the abutment teeth should have a good periodontal condition. The condition of the bone loss should be minimal in the abutment tooth, and the abutment tooth should follow the pericemental area. It should follow the Andy's law. That is, the pericemental area of the abutment teeth should be or more than the pericemental area of the replacement prosthesis. In case of defect, maxillary defective patients, this rule should suffice the criteria very well. So the periodontal condition of the abutment tooth should be very well, and one thing should be kept in mind while dissecting a segment of the maxilla, that the resection line should be far away from the abutment tooth. Otherwise, that will lead, if the resection line is close to the abutment tooth, that will lead to bone loss in the abutment tooth, which will make the abutment very less susceptible to uh, retentive or occlusal forces directed by the rest. If they are bicuspids, the rest seats should be on the mesial occlusal aspects. If this rest or rests are on one of the anterior teeth, cingulum rests must be well prepared so that displacement of the framework can be avoided, especially lingually or towards the defect. Like in this first case, the rest is prepared in all the teeth because the defect area is more and the teeth are less. So all the teeth are used. These all four teeth are used as a abutment, and rest is prepared on all the teeth. So the retention is highly increased. And this is the final prosthesis with a high bar on the canine. This is defect and this is the prosthesis. Now here the rest is on almost all teeth, all the both the molars and the first premolar and the canine. The rest is placed, so that will enhance the retention and stability of the prosthesis. Fulcrum line. The fulcrum line for class 2 maxillary patients is dynamic in that it shifts or changes during mastication. Patients with tapering arches having linear tooth and arch arrangements will tend to exhibit more movement around the fulcrum line as compared to patients with square and ovoid arch forms. The concept also demonstrates the importance of saving as many teeth and as much of the premaxillary segment as is possible on the defect side. So, as we see in this picture, the fulcrum line shifts readily. It is a dynamic fulcrum line. The meaning of the dynamic fulcrum line, that is, the fulcrum line shifts during function. When the load is applied on first position, the load 1, when the load is applied on this position, the fulcrum line is AB. When the load is applied on position 2, that is on the lateral incisor area, the fulcrum line shifts from AB to CD. When the load is applied in the posterior region, that is in 6-7 region, then the fulcrum line shifts from CD to EF. So in such cases, when the fulcrum line is dynamic, multiple rests are needed. That is why rest is prepared in the AB position, one is prepared in the CD position, the other one is in the EF position. So when the fulcrum line shifts, the rest or the load on the rest is also shifted. So more rest is important, and ultimately more tooth is needed to be saved to increase the rest and increase the retention of the prosthesis and to decrease the number of fulcrum lines, because as the number of tooth abutment tooth decreases, the number of fulcrum lines increases. Because if posterior teeth are present in this area, then the load on this, the fulcrum line A and B, is decreased or is not present there. Only two fulcrum lines are present. So more teeth structure is, more tooth saved, less the fulcrum line present. Now, effect of trismus. An alternative is to record as much of the palatal surface, teeth, and defect as possible if the master impression for the removable partial denture frame. Often, a sufficient amount of palate and teeth will have been recorded to accommodate an interior strap palatal major connector. As shown in this figure, the mouth opening is A and the tooth size is B, and from the tooth up to the palate it is C. So we need to place the prosthesis, or the width of the the length of the prosthesis is B plus C, but we have a space of A for insertion. So in such cases, we need to minimize the length of the prosthesis, or we can say that we need to minimize the bulk of the prosthesis, or the prosthesis which is going into the defect area. It needs to be reduced. After the partial denture framework is fitted and physiologically relieved, the defect is recorded with an altered cast impression. In these circumstances, trismus will also limit the extension up into the defect, especially along the lateral wall. Altered cast impression is taken with the framework already placed in the mouth, and an alginate impression is taken with the framework, in which the framework is picked out with the impression and another cast is poured. Now, class 1 design. The design can be either linear or trapodal. 2 or 3 anterior teeth are splinted whenever possible, and support is derived from the central incisor in the most posterior abutment tooth. If the dental arch is curved, the principle of effective indirect retention is utilized by the location of a rest on the canine or on the distal surface of the first premolar in a tribodal design. So this is a tribodal design. So in this design, 2 or 3 anterior teeth are splinted wherever possible, and support is derived from the central incisor in the most posterior abutment tooth, like this. Yeah, so it is basically the rest should be on anteriors and on the most distal most position tooth. Direct retention is obtained either from the labial surface of the anterior teeth with a gate design or an eye bar on the central incisor. Posterior retention is placed on the buccal surface of the molars. In bracing is located palatally. Class 2 design. In this class, the premaxilla on the defect side is maintained. The bilateral design is similar to a Kennedy class 2 removal partial dentate design. A tribodal design is recommended. Splinting of the 2 teeth adjacent to the defect is advisable. Primary support is placed on the tooth nearest to the defect as well as the most posterior molar on the opposite side. So this is the primary retention which is on the adjacent tooth, that is on the canine, and from the most distal molars. Okay, so this is the an indirect retainer is positioned as perpendicular to the fulcrum line as possible. Here, the fulcrum line is from this is the fulcrum. This line is the fulcrum which passes from the abutment tooth, most distal, most adjacent abutment tooth, from the most posterior most teeth. So the indirect rest should be placed perpendicular to the fulcrum line. So indirect rest is placed on this canine and premolar. Position as perpendicular fulcrum as possible. Guiding planes are located proximally on the distal surface of the anterior tooth and the distal surface of the molar. Retention on all abutment teeth is located on the buccal surface, and stabilizing components are placed on the palatal surfaces. Class 3 design. The defect is located on the central portion of the palate and all of the dentition is preserved. The design is based on quadrilateral configuration. Support is widely distributed on both premolars and molars. So here, a quadrilateral configuration is there. The support is obtained from premolar, both the premolars and both the molars. So it is a quadrilateral configuration. Class 5 design. The defect includes the premaxilla on the non-surgical surgerized side. The design is linear. Support is located on the center of all remaining teeth. Retention is located mesially on the premolars and palatally on the molars. Stabilizing components are palatal on the premolars and buccal on the molars. So here the number of tooth is less. So there is more fulcrum lines. So support from all the teeth is taken. So it is basically a unilateral type of configuration, but because of less teeth, the support is taken from both the sides of the teeth, buccally and also palatally. Class 5 design. Splinting of at least 2 terminal abutment teeth on each side is suggested. Eye bar clasps are placed bilaterally on the buccal surface of the most distal teeth, and stabilization and support are located on the palatal surfaces. This is basically a trapodal configuration. A gate prosthesis is a viable alternative for these patients. So in this, the tooth structure, so the tooths are present anteriorly, which has less perisegmentality as compared to the posterior teeth. So we have to replace the posterior teeth. So the anterior teeth are splinted, or that abutments are splinted to increase the retention for the prosthesis. Class 6 design. In side defects, 2 anterior teeth are splinted bilaterally and connected by a transverse splint bar. A clip attachment may be used without an elaborated partial framework if the defect is large or the remaining teeth are in less than. So this is the anterior teeth or the most distal abutment teeth are splinted with a bar. So this will increase the retention of the prosthesis. Clinical procedure. The master impression is made in the framework designed and fabricated as previously described. The obturator portion of the prosthesis should be constructed of acrylic resin to allow for adjustments and relining. Finishing liners of the cast metal framework should be established on palatal mucosa short of the palatal shell. The retention loops for the obturator portion should extend well across the palate and in some instances into the defect and be located approximately 1 to 2 mm superior to the normal palatal contours. This is the primary impression taken with the hydrochloride impression material like alginate. This is the cast. On the cast, a framework is fabricated. On the framework, we fabricated a custom tray. With the custom tray, with the help of border molding, and the final impression is made. This is the border molding done with a impression wax, that is the correcta wax or modeling plastic. Then on that, final impression is made with zinc oxide urinal impression paste or light body can be used. An altered cast impression is poured and the cast is mounted. So this is the altered cast impression and the cast is mounted with the help of occlusal record. Pressure indicating paste will be displaced or distorted when seating the prosthesis into undercut areas. Therefore, disclosing wax is preferred over pressure indicating paste to identify areas of excessive tissue displacement in the defect. The patient is given recall appointments in a manner designed to gradually extend the interval between appointments. Dentulous patients with partial maxillectomy defects. The prosthodontic considerations for the dentulous patients by dentulous partial maxillectomy patients are similar to those of the total maxillectomy patient, except that the prosthetic prognosis improves as the margins of the resection moves posteriorly. If the maxillary cuspid on the defect side remains, the prosthetic prognosis improves dramatically. Even the presence of a central or lateral incisor on the defect side will enhance the stability and support for the prosthesis. The fulcrum line is dependent on the placement of occlusal rests. As more teeth are retained on the defect side, the fulcrum line shifts posteriorly. If both cuspids remain, the fulcrum line will be similar to the conventional Kennedy class 2 partial dentures. As the fulcrum line shifts posteriorly, the superior distolateral extension of the obturator should be lengthened, as extension into this area offers the greatest mechanical disadvantage because it will be at a right angle and most distant from the fulcrum line. So this is defect. Defect is covered with a gauze piece soaked in saline or betadine, and then the impression is made with the alginate impression material. Other required maxillary defects. Defect bordering hard and soft palates. Pleomorphic adenomas and small well-localized squamous cell carcinoma may require limited surgical resection at the junction of the hard and soft palate. Often the alveolar ridge and teeth are only minimally involved in the resection. Construction of an obturator for this type of defect is more difficult than it appears, as the obturator must maintain contact posteriorly and laterally during soft palate elevation. So this is the defect. But in such cases, the problem is that when the obturator moves, the soft palate is also moved. So they're creating a space between the obturator and the soft palate. Schematic drawing of the movement of the anterior margin of the soft palate during palatal elevation. Impression for recording the functional movements of the tissue bordering the defect are recorded with thermoplastic waxes. So this is the impression recorded with thermoplastic wax. Altered cast technique is used to bore the impression. Speech is usually normal after delivery of the prosthesis. Occasionally, however, the patient will not access nasal leakage when swallowing. To alleviate this problem, an extension of 5 to 10 mm is created across the intact soft palate. The soft palate will lift from this extension in function, but this shield will serve to direct liquids and food into the oropharynx. Leakage will be minimized without interfering with tongue function. Extension into the defect to establish contact with the nasal side of the soft palate during elevation is also suggested. This is the closure of the defect. Anterior defects. Occasionally, an anterior resection of the maxilla is required. A scar band is usually present at the junction of the oral and nasal mucosa. If a skin graft is not placed, the nature of the defect anteriorly may limit an extension. However, the prosthodontist should try to extend the anterior surface of the prosthesis as far superiorly as possible without interfering with nasal physiology. This is the anterior defect and this is the final prosthesis in place. Total palatectomy defects. Bilaterally total maxillectomy defects do not occur frequently. When both maxilla have been excised, the prosthetic prognosis is quite guarded. Prostheses constructed for these patients are primarily for speech and aesthetics. Without bony support, the prosthesis will exhibit considerable movement during swallowing and mastication. Retention, stability, and support are enhanced in these surgical undercuts. These surgical undercut areas are located bilaterally and lined with a split thickness skin graft. Engagement of the nasal aperture is useful in some patients. Implants may be useful when placed in zygomatic buttress areas in selected patients. This is the implant placed in the zygomatic buttress area. This is the female component for the to engage the implant abutment. Orbital floor defects. On occasion, removal of large portions of the orbital floor is necessary to ensure tumor control, resulting in ptosis and anophthalmosis. In these patients, prostheses are often useful in providing support for the orbital contents. Uplifting the orbital content will improve cosmetic appearance and often reverse the diplopia. When significant amounts of the periorbita are removed, compromising adequate inferior oblique and inferior rectus action, the incidence of diplopia increases. They may be fabricated as a one-piece prosthesis in which the antral extension is attached directly to the orbital section or in two sections, in which the superior orbital extension is connected via attachment to the parent prosthesis. The antral section may be flexible or rigid. A flexible apparatus is advantageous because it is light in weight and can be designed so that transmission of movement generated by the parent prosthesis during function is minimized. Evaluation of the maxillary obturator prosthesis. Function and vestibular limitations. Clinical observations indicate that edentulous patients with maxillary obturator prosthesis do not function as effectively as do conventional complete nature patients. A patient with a maxillary resection prosthesis is compromised in both areas because of the defect in surrounding sensory deficit. The added movement of the edentulous maxillary resection prosthesis up into the defect accentuates this functional disparity. Retention in the classical sense of complete dentures is unobtainable because the surgical opening permits the leakage of air beneath the prosthesis and eliminates the retentive contribution of atmospheric pressure. Shipman studied 10 dangerous patients with maxillary recession obturated prosthesis. A nathodynamometer was attached to each prosthesis. The maximum bite force recorded was approximately 50% of the forces that reported for conventional denture patients and had little relationship to the size of the maxillary defect. The denture adhesives improved performance approximately 12%. Air and fluid leakage. During forced exhalation, the soft tissues parallel to the obturator contracts more vigorously, leading to improved seal. With sustained exhalation, forceful exhalation is not visible and therefore leakage is more likely to occur. Posterolaterally, the functional movements of the coronoid process may contribute to leakage. During swallowing, the dorsum of the tongue elevates forcefully against the hard and soft palate, creating a pressure superiorly, which may force fluid around the obturator bulb and into the nasal cavity. Patients often experience difficulty identifying the exact location where the leakage is occurring due to the sensory deficit associated with the surgical resection and the altered and compromised innervation with the skin graft lining in the defects. Speech consideration. Oral nasal resonance balance is distorted as the patient cannot confine oral emissions within the oral cavity, leading to hypernasal speech. Consonant phonemes used in the English language require labiodental, linguodental, and linguopalatal contacts. Maxillary resection may affect velopharyngeal function by destroying the attachments for the palatal musculature. By coincident denervation of the palatal muscles or by the relative shrinkage and immobilization of the soft palate through scar contracture. Relining of the maxillary obstructive prosthesis. Relines are required more often for patients with maxillary defects than for complete denture patients. In large defects, much of the support, retention, and stability for the obstructive prosthesis is derived from the soft tissues of the defect, and these tissues are subject to change. The cheek surface and scar band at the junction of the skin graft and oral mucosa tend to stretch with time. The posterior margin of the defect is also subject to change if it extends into the area of velopharyngeal function. In addition, the medial bony margin of the defect remodels and becomes rounded. The reline must be performed with care and precision, maintaining centric relation in the vertical dimension of occlusion.